1 is gone, lower trapezius. When the teres is gone, then you don't have external rotation 2. That is when the lat dorsal will be more biomechanically more viable. So I would like to bring out this particular very interesting surgery, the muscle advancement. So here I will, what is the muscle advancement? Muscle advancement is when you have an irreparable cuff, when the supraspinatus and as well as infraspinatus is gone. This is a technique of elevating the muscle, especially in these kind of scenarios. You can see irreparable cuff, significant retraction, inelasticity, muscle atrophy, fatty infiltration. All the classic features of irreparable cuff is there. You can see Pate's grades, Hamada grading. So these advanced grades you definitely have to go in for when there is arthritis, you have to go in for RSA. But you definitely have this option called muscle advancement. So what is muscle advancement? It was by Dr. Morihara in 2007. What he did was he elevated the muscles, that is supraspinatus from the supraspinatus fossa, the infraspinatus from the infraspinatus fossa, then did a regular release on top of the supraglenoid area. So then the muscle becomes completely free and you're able to bring the muscle back to its footprint attachment. You can even get around 5 centimeter, up to 5 centimeter of retraction. Retracted muscle can be brought back to the footprint with a repair which is tensionless. So this is how it is done, and you definitely do it arthroscopic. The release is inside the joint. You can do a mini open on the middle part of the scapula. I'll show you the technique by how we elevate this completely. So this is a patient who we had and who had these particular findings. This is the clinical findings.
How are you?
So the mid, you can see how we open it first. First you identify the spinoscapula. You need an incision which is 2 centimeters above the spinoscapula and 2 centimeters below the spinoscapula. So this is done when you go subcutaneous. First, next you find is the trapezius fibers. You have the middle trapezius and the lower trapezius fibers. So you split these fibers parallel. That means parallel to it, a scissor split it like that, and then put a Langenbach. You put one small Langenbach above and one below. So basically, you are opening that window, and immediately under this, you can see the supraspinatus. You can see this, so you can actually feel the supraspinatus, and you can even feel the spinal scapula very nicely under this trapezius. Once this is done, what you do is you take either a knife or a cautery and you just cut it along the middle border and then keep pushing it with a cob. Now, how much is the safe distance of the cob? The cob should be going up to around 3 fingers from the acromion. That is your end. That means if you see the acromion, lateral of acromion, it should go up to this much. So that is kind of a safe landmark for you to go. So here, after this, mostly in this kind of significantly retracted tears, I do the releases first. I do the muscle slide first, and then I go in for the arthroscopy. Because what happens is, when you do the scopy first is that a lot of fluid extravasation is seen, and sometimes it's very difficult to find the muscle. The supraspinatus becomes kind of very mushy, and you will not be able to even find it properly. So those kind of cases where I've decided that I'm going to do an advancement, I do the advancement first, the slide first, and then you do the release. You can see we have to do an extensive release here. Extensive 360-degree release. You are going supraglenoid up to around 1.5 centimeters. You protect the nerve there, and you do a subacromial decompression. If the AC joint is affected, do a AC joint decompression. Then the most important step of this surgery comes, which is basically the suprascapular nerve release. So I will show how this is done, but how do we identify the suprascapular nerve? The suprascapular nerve would be, you trace the AC joint, go beyond the AC joint, then the first structure you see from up to down is the CC ligament. So once you see the CC comes like that from up, and then it goes like that. So this horizontal portion of it is the transverse scapula, so ligament. So this transverse scapular ligament, just under that you will be able to see the nerve and you can release it. And see, the particular step I'm doing is I'm identifying the coracoid. I've done a CHL release as well. Only then you can really mobilize this particular tendon. So Here I'm going for a suprascapular nerve release. So you again, what the structure